We just have a couple minutes. I want to poll the panelists. A question came through from the audience. Do you routinely stop aspirin or other blood thinners with MIGS?
I can answer that. So I routinely do stop blood thinners. In knowing that there can be risk for some type of bleeding, I want to minimize that to the furthest extent. Also, when I'm examining a patient, I ask, what are they on blood thinners? That includes the baby aspirin. That also includes if they're on fish oil. And I have them hold off for at least a week prior to the procedure. Another important question I ask are, do they bruise easily? If you just have them look down at their hands and see that there's bruises all over, this is someone who, if they need to stay on chronic blood thinners after the procedure, still could pose potential risk for some bleeding afterwards that I want to be able to avoid. So blood thinners is a big thing that I address preoperatively.
Tom?
I do not for iStent or Hydrus. I probably at least request that they consider it, the internist that is, for GAT or KDB incisional procedures. But I never personally stop them. I say, you know, if the systemic risk isn't too great, it would probably help me if they were off. And I say at a minimum, make sure they're not super therapeutic. You know, I want them low therapeutic range if they continue on.
Sorry, I wanted to interject. I agree with Tom in that when it does come to iStents, I do have a little bit of a lower threshold for concern of bleeding, especially if they do have to stay on chronic therapy because of their systemic risk factors. So I do admit that there are certain procedures that the bleeding is less, and I'll have a little bit more leeway in terms of being concerned highly about that. But more so the goniotomy procedures, I expect the bleeding to occur because that's part of the sign that you're in the right space. So those ones I'm very aggressive.
One more question. Do any of the panelists have experience with ab interno blood revision with cataract surgery in this particular patient?
Yeah, I mean, I perform it relatively frequently. What I'll do is I'll needle the bleb from the outside.
Can you turn on the mic for Dr. Mossad, please?
Can you hear me? So I'll often revise the bleb from the outside with an angled MVR. I'll go posterior to the bleb, break up any adhesions, and then I'll go ab interno with a cyclodialysis spatula and raise the flap, and then squirt some BSS in and make sure that the bleb elevates. So that's a nice way of, without opening up the bleb, to make sure that your flap is open and there's any adhesions in the scleral flap are broken with the cyclodialysis spatula.
Tom?
Leon, I mean, I've done that as well, and to me it depends on how bad the glaucoma is. I think it's a little bit glaucoma roulette. You can get some really low pressures doing that, and so in my opinion, the patient, you need to justify the risk that the pressure's 2 or less the next day, and I'd certainly make sure you leave the OR knowing that you've got some resistance to outflow. I think we can't titrate that kind of a manipulation.
So, you know, the way I look at it, I usually look at the trabeculectomy bleb. If the bleb is fairly flat, then I think they have episcleral fibrosis. Then I typically will go in ab interno and lift that flap and kind of dissect underneath. If they already have a focal bleb like you did where it leaked, then I think the external approach, I don't think we need to, you know, in that case, there's already flow. I wouldn't necessarily even go internally. Just use maybe the IA from the phaco to form the bleb. And then I always suture these incisions because, like you said, if pressure could be very low, that incision may burp open from the cataract incision. Okay, so we'll have time for other questions after. We're going to go to the next session. The next session is cataract surgery concerns in short eyes, that's small eyes, in small eyes with narrow angles or angle closure. And we'll start with Michelle Lim. Michelle is going to offer some of her pearls and her approaches, and then Brian Francis will address some of the surgical. Oh, sorry. There's an ARS question. Can we add the ARS question, please? That's question 3. This is a 65-year-old with moderate hyperopia who presents with narrow occludable angles and mildly elevated pressures, 23 to 24, with no glaucomatous optic neuropathy. But with the 2025 to 2030 vision related to the cataract, patient is relatively asymptomatic except for driving difficulty at night, what would you recommend? Laser PIs, patient is asymptomatic, can have cataract surgery later, or cataract surgery, just open the angles, be done with it. Cataract surgery plus perhaps trabeculectomy with mitomycin C, let's really lower the pressures and improve the vision, or let me decide after these presentations. Okay, so the results. Majority would do cataract surgery, and some, about 30% would do laser PI.